Hello and welcome to this prostate cancer support podcast on focal therapies. Let me introduce you to Mr. Taimur Shah, who is an associate professor, senior lecturer and consultant urologist at Imperial College London. Mr. Shah has a specialist interest in prostate cancer diagnostics, which includes focal therapy. Mr. Shah qualified from University College London, where he was awarded a first-class honours degree in molecular medicine. So, good morning, Taimur.
Good morning. Thank you for having me on. It's a real pleasure to be helping with this and trying to explain what focal therapy is and what it means from a patient's perspective.
Can we start with, for a layman like me, what exactly is focal therapy?
Traditionally, we really only had two treatments for prostate cancer, and that's been surgery to remove the prostate, which we now do robotically, or radiotherapy, which again treats the whole prostate. And these treatments were given and offered to patients regardless of how much cancer they had within the prostate itself. So it didn't matter whether they had a little bit of cancer on one side or if they had cancer on both sides. And what we find is that men unfortunately have some side effects from these treatments. They're really good treatments for cancer, but they do have side effects, particularly to do with urinary function, so incontinence or bladder problems. Incontinence more common with surgery, and bladder problems, so peeing more often, blood in the urine more common with radiotherapy, but also bowel issues sometimes can happen with radiotherapy as well. And also sexual function, unfortunately. So both these treatments have a big impact on the ability for men to have an erection, but also to ejaculate afterwards. And over the last 10 years, we've developed this surgical, minimally invasive surgical technique called focal therapy. And the theory behind it is that if you only have cancer on one side of your prostate, so the left-hand side or the right-hand side, why do I need to go and remove the entire prostate? Or why do I need to treat the entire prostate with radiotherapy? Why don't I just focally treat the area of cancer? And the reason this has really only been taken up in the last 10 years is because we needed a big change in how we diagnose prostate cancer. Previously, as many of you will be aware, we used to examine with our finger. We used to put needles into the prostate through the back passage, and this was all random. There was no way for us to tell whether someone had cancer or not, or any scan that we could do. We've now got MRI scan, and this very clearly in many men will show where the cancer is, and we've got transperineal really accurate targeted biopsies we can do to confirm what that cancer is. So stands to reason, now that we can see the cancer and we're able to really accurately tell whether it's on one side or the other, then actually we should be able to use various energies that we have available to us to just treat that area. And the aim here is that you actually control the cancer, so you prevent that man from having problems later on in life with prostate cancer, potentially even dying from prostate cancer. But you don't have to treat the whole prostate. And the biggest gain that we get is by not having to treat the whole prostate, we actually get much better side effects. So generally speaking, and I'll go through what the various energies for focal therapy are, but generally speaking, all of these energies, the biggest kind of the benefit to the patient is a very, very low rate of urinary problems, so namely incontinence. After radical prostatectomy to remove the prostate, even in best hands, about 1 in 10 men will probably be wearing a pad for the rest of their life. It can be higher in some data sets that I've seen. With focal therapy consistently across the board, whether that's in the UK or worldwide, it's about 1 in 100 will have any form of leakage at all, which means 99 out of 100 men will not have any urinary leak afterwards. There is a bit of a recovery. It does take a few weeks, but after that, most men do quite well in terms of a urinary standpoint. And then same with erections. About 1 in 10 men will notice a drop in how good their erections are. Now, many might not be able to ejaculate, but all the pipe work is still there. So some will, many won't, but actually most will still be able to get an erection after treatment, which essentially counters the two main side effects we've seen with surgery, robotic surgery, even to remove the prostate, or radiotherapy.
Is focal therapy just one thing, or are there different types of focal therapy?
There's lots of different energies, and you'll see a lot of words thrown around, and actually, unfortunately, it can it can make it quite difficult to sometimes interpret what is being said. And the reason we have loads of different energies, and we've got really three in the UK that we've got a lot of experience with, is to do with where the cancer is within the prostate. All of these energies do the same thing. They destroy the area of cancer and they leave healthy prostate tissue behind. But because the prostate is a certain shape, we have to use different energies to target different parts of the prostate. So if you have a cancer at the back, we tend to recommend something called high intensity focused ultrasound. This is where you focus ultrasound waves so they create intense heat. This is really good for cancers at the back because we can aim the ultrasound waves into the prostate, but the problem we get is that they can't go very far in. So cancers that are at the top of the prostate can't really easily be reached with HIFU, but cancers at the back get treated really, really well. Similarly, we've got cryotherapy. This is where we put needles into the prostate and freeze down to less than minus 40 degrees, sometimes less than minus 100. And if you can imagine, nothing survives that temperature. But that temperature we can only really control at the top of the prostate, because if you can do it at the back of the prostate, the problem we have is that you have your back passage, and what you don't want to do is to make the rectum or the back passage too cold. So we usually use cryotherapy for cancers at the top of the prostate. And then we've got one of the newer energies called IRE, or irreversible electroporation. It also goes by nanoknife, so lots of names for the same thing. It's a newer treatment. We've got a bit less experience with it. And what we find is for slightly smaller cancers at the top of the prostate, possibly near the edge, we can get very good treatment, but whilst minimizing some of the damage to the surrounding tissue. So we're also now starting to use IRE in some cancers, mainly contained in the top half of the prostate. They all work differently, but the end result is still the same. They're damaging cancer cells.
Is this treatment available everywhere? I mean, I've heard the terms, but certain hospitals, I believe, do it and certain don't. Is that correct?
That's correct. So it is NICE approved through their special procedure guidance for all focal therapies, essentially HIFU, cryotherapy, and IRE, which means that any hospital in the country can offer it. And as with all things, there's early adopters, there's people who did the research, such as ourselves. My PhD was entirely in focal therapy. So we were the groups that started off doing this and started to produce the data so that other doctors, other surgeons, and then ultimately patients can see it and say, is this something that they'd want to do? And unfortunately, it does take time. It does take time for people to adopt this technology. And it is available to everyone, but it's generally been confined to a few hospitals around the country. One of them is us at Imperial College London, but we have others, such as University College London Hospital, which is down the road. We've got centres in Southampton, Basingstoke, Brighton, that have traditionally been doing it. Up north, Liverpool have done cases, and so have Newcastle. But now we're starting to see more and more places open up. So Bath recently opened up their program. Norwich recently opened up their program, and we're starting to see more centres. At the moment, it isn't available everywhere. I'm hoping it will be over the next few years, but it takes time for centres to get the funding, and we're obviously in a cash-strapped NHS, but it takes time to get the funding and to get the equipment and ultimately learn how to use that equipment properly. So it is available to all. If it's not available in a local centre, what the NHS structure allows us to do is to actually refer patients to a nearby hospital. So we take a lot of referrals from around the country for patients who would like an opinion. And we'll have a look at the scans, we'll look at all the biopsies, we'll look through the case, we'll talk to the patient and say whether we think they are or they aren't suitable, and if they would like treatment, we'll offer it down here in London.
So from what you've been saying, it does involve quite a bit of work to ascertain the, if I can use the expression, fit between the patient and the treatment.
That is a really important point. So, as I said, we're generally talking about cancers that are contained to one side of the prostate. We will sometimes allow treatment if you have a very small amount of low risk or medium risk cancer on the other side, but not every patient is suitable. So we have to assess all the scans, all the biopsies to make sure actually this is the right treatment for the patient, because what we do want to do is to get really good outcomes from a cancer point of view and side effects. But if the cancer is not suitable, then really you should have something else, something like robotic surgery or radiotherapy. And so we have a MDT, a multidisciplinary team meeting, where we review the case, and then we feed that decision back to the patient.
From what you said earlier, it would seem that with focal therapy, there is less risk of side effects as against, for example, radiotherapy or a radical prostatectomy. To what extent is focal therapy better? Can you give a percentage around that?
So I'll start with surgery, and I will use the better figures for surgery, uh, which is that about 1 in 10 men will get long-term leakage of urine. That means having to wear a pad or something in their underwear daily to prevent some urine staining their clothing. But the vast majority of men leak immediately after surgery. Some don't, but most will have some leakage, and they will have to do pelvic floor exercises. They will have to adjust what sort of fluids they drink, how much they drink, when they pee, to try and get control back. And that control can take 3 to 6 months, and in some it can take up to a year to get better. So overall the number is 1 in 10, but it's a bit of a journey to get continent in the 9 out of 10 men who do regain continence. The difference when you offer focal treatment is that almost all men are continent after surgery. Very, very few leak immediately afterwards. So there's no recovery period to regain continence. And the small number who do leak often usually get better within a few weeks to a few months. And long term, only 1 in 100 has leakage. And that leakage is often not very heavy, because we've normally treated part of the prostate, have not treated any of the surrounding structures. Similarly with erectile function. After surgery, some men have erections, brilliant, but most do not. And if you're going to get them back, it can take even longer than the urinary problems. It can take 6 months, 12 months, sometimes even longer. And generally speaking, I say that only about half of men will ever get their erections back, and that's with medical help. That may be tablets, that may be some other treatment that we've had to give to try and get their erections back. Difference with focal therapy is that most will have erections. They may notice that they take a little while to come back. Nerves are fragile, they take a little while to recover. They get stunned, and that can take a little while to improve as well. But generally speaking, by about 3 to 6 months, most men have regained their erections, which is again a big difference to what we see after surgery. Radiotherapy also has side effects for bowel, for bladder, and actually a lot of patients with radiotherapy also have to have hormonal treatment. It may only be for 6 months, but it will have side effects. It's like going through the menopause, but for a man. You lose all your testosterone whilst you're on these hormonal tablets, and that can make you feel tired. You can have difficulty concentrating. You might gain weight. But we need to give these treatments with many prostate cancers because it improves the outcomes from radiotherapy. It makes radiotherapy better, but it does give you side effects initially. And then long term, radiotherapy can also, because the prostate's not a perfect square, you will get radiation to the bladder, which sits above the prostate. You will get some radiation to the back passage, which sits behind the prostate. And it means that some men have to go to the toilet more often, so they're having to open their bowels or to urinate more and more often. They may get blood in the back passage. They may get blood in their urine. And roughly speaking, at least 1 in 10 will need to have some form of medical treatment to help with these symptoms later on. So it isn't completely side effect free. And then actually erections will suffer. The loss of testosterone you get with the hormonal treatment will prevent you getting erections afterwards, but actually the radiation will also damage nerves. The benefit with focal therapy is if we're doing it to only one side, even if one nerve is damaged, it's usually only partially. You have 2 nerves for erections around that surround the prostate. Both surgery and radiotherapy, doesn't matter how careful you are, how close you try and treat the prostate, you will get damage in some form to both nerves. So radiotherapy also causes problems with erections, probably in a similar number to surgery, probably slightly less. but still a significant number of men will have erections. And if you've had to have hormones for a longer period, there is a chance that your testosterone may not recover.
So it does sound, if you are a fit for focal therapy, overall it is a much better treatment than going for the radical prostatectomy or the radiotherapy.
Well, it's a different treatment. I do both. I do surgery. I do robotic surgery to remove the prostate. I do focal therapy, and I refer many patients onto my oncology colleagues for radiotherapy. They're all good treatments for prostate cancer, and they've all got their pros and cons. So the benefits, and when I'm talking to my patients, I try and explain to them to try and help them choose what the benefits and the negatives are. There are benefits from having surgery to remove the prostate. It's potentially the only one procedure they may need in their lifetime. So if I remove the whole prostate, the chance of needing more treatments is less than 1 in 10. So most men hopefully won't need further treatment, but they'll have to unfortunately contend with some of the side effects that come with that operation, even if I've done a nerve sparing procedure. Whereas with focal therapy, because I've been targeted, there is a group of men who will need a second treatment, and that number is higher. All of our data is, as I said, about 10 years old. So over a 10-year period, I'm not seeing more men who are dying from their prostate cancer or developing spread of their prostate cancer. The numbers are about the same as if they'd had surgery or radiotherapy. But about 1 in 4, maybe 1 in 5 will need a second treatment. And that's because I've been targeted to that area. Now, I'm treating what I can see on the MRI and what I can see on the biopsies. So I'm not going to treat the whole prostate because that defeats the point of doing focal therapy. But you could get cancer that some cells that are left at the edges that I don't know about that can grow over time. And you've got completely normal prostate. The other side of your prostate's been untreated. That could develop another cancer over a man's lifetime. And then equally, even within the area of treated, very occasionally there can be cells left. For whatever reason, the energy, although all the devices say it's gone across uniformly, we only need a few cells left behind that can grow over time. These are unlikely to spread. These are unlikely to lead to a man dying from cancer as far as our data suggests. But it does mean that over a 5-year period, about 1 in 4 to 1 in 5 need to have a second treatment, either to the same area, to the edge, or to somewhere else in the prostate. The side effects are not much worse, but they will have to accept that potentially going down a focal route could mean a package of true treatments. And in some, unfortunately, I still need to remove the prostate later on, or offer them radiotherapy, and that number is about 1 in 10. So the vast majority will avoid surgery or radiotherapy. Some will need a second treatment. Most, hopefully, will be fine with just one. But that's the trade-off. That's the trade-off you make by going down that route.
I think every treatment has a trade-off.
It's my aim here is to educate and try and give the information and try and explain what I know about the treatments and what happens to patients afterwards. And it's for them to decide what they find most important in their treatment, which bits they like, which bits they don't like, and then choose based on that.
That's exactly what we're trying to do with this podcast. To put information out there, both from the patient's point of view and from the clinician's point of view as well, so that men can better understand all the options that are actually out there and consider them. I was treated with brachytherapy, which I guess is an older version of focal therapy. But in doing so, I had to go through a lot of considerations to decide that brachytherapy was the operation that I actually wanted. At the time, there was scant information out there. And what we're trying to achieve with this podcast and with your help is to make men aware of what there is out there. It may or may not be suitable for them, but at least they have the opportunity to think about it, discuss it, and consider it for their own personal treatment.
Brachytherapy, by the way, is a good treatment. It's a radiation-based treatment. It's not truly focal because it treats the whole prostate, but it does minimize the side effects you get from radiotherapy. The problem is with most brachytherapy, their criteria for treatment are quite strict. So they tend to not treat some of the patients that we would offer focal therapy to. So no, if brachytherapy is available, I think many centers still do it. It is a reasonable treatment for intermediate, so kind of medium risk prostate cancer.
Yeah, and we have podcasts planned to cover brachytherapy as well. You've talked a lot about these therapies. I'm up here in the north of England, you're down in London. Is it possible to refer people from other hospitals to yourselves?
Yes, we've got a whole network set up, and we've got a multidisciplinary team meeting set up to essentially give opinions to patients on whether they're suitable or not. So the referral can come through the patient's GP or through their actual diagnosing hospital. It comes through to us, we look through all the scans, and we will very quickly give an opinion back whether someone is suitable or not. And yes, we are more than happy to review any patient, speak to any patient wherever they are in the country, and at least point them in the right direction, or give them more information on whether they're suitable or not.
Taimur, thank you very much for coming today and talking to us. I've personally found it very illuminating. I've heard some of the terms before. I didn't know exactly what they meant. It's educated me a lot more. And I'm sure this podcast will prove invaluable to men who are considering their options about how they're treated for prostate cancer. So a big thank you from all of us.
Thank you.